I'm Taryn Soto. I'm the program manager for Crisis Services. Somebody would contact Crisis if they were having an increase in mental health symptoms, which is very unique to them. So it could be somebody who's just feeling an increase in anxiety or an increase in depression, but it's very unique to that individual. It's not a one size fits all because everybody experiences their mental health symptoms differently. So crisis is short term, but there's never a limit on it. We have people who call our crisis line all the time just for additional support, and it's a great resource to have in the community for people who don't know where to access services or just don't have anybody to talk to that isn't in their daily life. So people can reach out as much as they want to, and they can be seen as much as they need to. It's just about supporting them in their time of need. We have our crisis line, which is 24/7, and it's manned by our crisis workers, and they can call that whether they're in crisis or they just need to talk with somebody. They can come to our crisis offices. We have 2 locations, one in Ukiah and one in Fort Bragg. We see people in the emergency rooms 24 hours a day, 7 days a week. But people also can reach out to 911. People can reach out to their primary providers. They can go to a school. There's no wrong way because our main focus is to make sure that people are feeling supported in their time of crisis. If somebody's in crisis, it can easily go from somebody just feeling an increase in their depression to somebody feeling suicidal. So we treat them the exact same. They come in, we talk to them, we evaluate the situation, and if they do need to be placed in an inpatient psychiatric facility, then that's a different road that we take. But either way, when they come in, you always go in with an open mind and just being supporting and empathetic, because sometimes somebody who's really struggling can de-escalate and can feel a lot better just having somebody there who's supportive. Same thing if somebody starts to come in and they're just feeling a little depressed. When they talk about their depression, they can become suicidal. So it's all about how they're willing to accept the help and how they're willing to allow us to evaluate them.
The people that we serve the lifespan. Anybody that's having a crisis. And what's the definition of a crisis? A mental health crisis is defined by that individual experiencing it. So if somebody is having a panic attack and they believe they are truly in a crisis and they need support right now, then we're going to see them. If somebody is having hallucinations, is delusional, is unable to take care of themselves, we're going to see them, right? So that is the definition of a crisis. If we can avoid a restrictive environment, we're going to do that. If we can see somebody at the beginning of their crisis rather than at the end of the crisis and do some intervention with a rehab specialist, a therapist, and then also absolutely med management is a component to this, we're going to do that rather than ignore somebody in a crisis and catch them at the hospital 3 days later when there is no going back and there's only moving forward towards acute stabilization.
My name is Rick Menzer. I work for Redwood Community Crisis. I'm a clinical supervisor. We see people in crisis and they come in from multiple avenues. They come in from other agencies, other community partners. Sometimes we'll get a call from CPS and they have someone in their office that is escalated and they're hoping we can come over maybe and talk to them and hopefully de-escalate that client. Not necessarily to put them on a 5150, but more and less like maybe we can help calm them down, maybe talk to them, maybe even get them into some services, because we are able, as being crisis, to get somebody in services immediately, where most of the other agencies are a referral process, a BPSA, which is an assessment. And so we're talking a lot of time sometimes between the initial episode and the actual them getting treatment. And sometimes it can be critical to get treatment sooner versus later. And so we're able to take someone and actually get them started on therapy, rehab, medication management. Those are our 3 key areas that we cover. And so our whole goal is to get them services quickly so that we can help them and help their family, hopefully normalize the situation and try to start solving some of the issues that they're having. And a lot of times it's not just with the client, but it's a family situation where, it's affecting the whole family. The family may be traumatized by what's going on. And it's really about trying to figure out the best way to help the entire family as well as the patient or the client get what they need in terms of services.
law enforcement sometimes does call us. And again, we don't have the staffing to be mobile. However, if I have the staff available, we're going to meet the person in the community. We would much prefer to meet law enforcement and the individuals in our community out and about and have a conversation, potentially bringing them back to our offices if possible, or maybe even resolving that issue out in the community rather than going to the hospital. Sometimes it's not possible, and that's okay, but there's an opportunity for rapport building right then and there, not just with ourselves, but also with the officers that are there. You know, we all live in this community, and we're all very invested in making a difference. And so we're trying to, when we go out and we're meeting them in the community, we're trying to use that least restrictive opportunity. If we can have a conversation and get somebody into a car, it's much better than having to use another method. If they're a danger to themselves, what is that underlying component, and how can we talk about it so that we go ahead and de-escalate the situation a little bit and then move them forward into a better environment, something with more privacy, coming to the office. You'd be surprised how quickly this can actually happen. Sometimes we don't have those opportunities, but we're going to take them whenever we can.
If we assess them and they're needing to be on a 5150 hold, we would have them come to the emergency room, or we would take them to the emergency room, and we would be with them until they're placed in a room, explain the situation. We always advise them that they are going to be on a 5150 hold, and we explain the process to them, which would be, not only will you be here, but we will be looking for inpatient psychiatric placement for you, and then this is the process when you get there. And if people understand and they have the information, then it's a lot less scary, and they see a familiar face, you know, that somebody that's understanding and empathetic. It can make all the difference between them really struggling in the emergency room and them feeling more comfortable with the situation and it being a positive experience for them.
People that haven't been exposed to like a crisis assessment, like a family member maybe is being assessed by a crisis worker or a clinician. Generally what's happening is they're talking to that patient and trying to determine if they're wanting to hurt themselves, they want to hurt someone else, or if they actually have the ability to make good decisions for themselves, which we would term as grave disability. Are you able to make decisions for food, clothing, and shelter that are actually good decisions, smart decisions, and are you able to process that information and actually take care of yourself? So what we're doing is we're trying to find out if that client's oriented, if that client has sort of a good rational sense of the situation, if they are able to keep themselves safe, or if they're having anger issues and maybe they're not able to keep someone else safe. So we're asking them questions about, you know, their relationships themselves, their ability to control their environment. And we may also ask them as far as helping the family. Is there anyone in your family that you can go and talk to? Is anyone that, you know, has, for example, is medication locked up? Is medication just, you know, available? Do you know how to get to it? Do you know where sharp objects are? Can you get to knives? Can you get to those kinds of things? Especially if they're talking about, I had a thought about going to getting a knife in the kitchen and maybe hurting myself. And so we want to know if they have access to those kinds of things. And a lot of times the patients are really very good at letting us know what they have access to and what they don't, which is very helpful. And it's also helpful later with the family, because one of the things we'll do is we'll do a safety in the home conversation where we go through a checklist of, you know, is medicine locked up or knives locked up? Is there anything else that, you know, could be harmful that's maybe available? Just to kind of go through a checklist, and then we actually provide that list for them to take home. So when they get home, they can make sure that they've gone down the list and taken care of everything. And so that becomes really important for the whole family as far as keeping, you know, everybody safe, not just the client or patient that we might have seen.
So for follow-up services, crisis is 60 days, and we are providing individual rehab, case management, and individual therapy, as well as referring out for medication management for adults. We also make sure that we are submitting referrals for Mendocino Medi-Cal beneficiaries to longer term services and coordinating to make sure that they're able to access those appointments. For youth, it is very similar. We provide individual rehab, case management, and therapy, but we also offer medication management, of course, if the parent is okay with it. We also submit referrals for youth too, to Tapestry Youth Project, as well as RCS. For youth, families are involved in every step of the way because they have to give not only consent, but they're very much a part of that children's crisis. They're in their environment daily. So what we are trying to do is really focus on what the crisis is. For example, behaviors. We work on addressing those behaviors and addressing it either in the community or at home, and sometimes in the office, just depending on the situation, because crisis is not a one shoe fits all. It's very specific to each individual and each individual crisis, because one person's crisis, is sad one day doesn't mean they won't be angry the next. Each crisis, each episode is different. So for kids, they could have increased anxiety in public spaces. We work with them slowly stepping that up to, maybe just in the office to outside, and really providing that support, as well as making sure that we're discussing with the therapist and the family what's going on to ensure that we're doing the best for the client. It'd be the same with adults. If they are willing to have their family included, then we try to include family, because really those natural supports and those community supports are what's going to keep the person stable, because when people isolate, they tend to have a increase in symptoms. Regarding family engagement, yes, family therapy is included as well as encouraged to ensure that everybody's reintegrating back to the community, whether it be a safety agreement or a psychiatric hospitalization, that they're reintegrating to the community feeling better and feeling like they went in and came out in a better place. Ensuring that, their environment is a huge factor on anybody. So ensuring that they get those needs met and that they're being heard is an absolute priority.
Not every solution is the same for every family, and that's all right. So if they decide not to have services with another provider, that's okay. If they end up having an increase in symptoms and they end up coming back to us, that's okay. We would just really love for them to have that continuation of care, and then have that therapist down the road decide when they're ready to just move forward with that additional services. But having an opportunity to give somebody a chance at having a better outcome in their life, it really is just priceless.
I got involved with crisis prior to coming to Mendocino County. I actually went to school in a master's program, and I interned in a mental health facility. So I actually worked in the inpatient unit. And so I started to see these people coming in that were schizophrenic or bipolar, and they were hearing voices, and there was a lot of kind of bizarre behavior that I was seeing. And I was really curious, like, how are you going to deal with that? What are the doctors going to do? What are the nurses going to do? What are the therapists going to do to try to help this particular person? And so I got to see kind of firsthand how they came in, and then after a few days, how they started to stabilize, and then eventually they would be discharged, back to where they came from, whether that be a home or a facility or whatever it might have been. And I was really just taken back by, number one, the seriousness of the issues that people are dealing with, and also just seeing the amount of progress that actually could be made with the proper medication and monitoring. What's meaningful about the work that I do in crisis and with therapy is actually seeing people get their life back, or get parts of their life back that they didn't believe they would get back.
So I was drawn to crisis because I saw what a huge impact it made on the community. When you see somebody in crisis, it's not typically on their best day, but being able to be there and provide that comfort, that shoulder or that ear for somebody, and seeing how much of a difference it can make just to be able to get that off their chest and be able to move on with their life is amazing. It is just the most fulfilling work to work with the community and work with people that might not get that chance or might not be able to build that relationship with somebody else. I did work in a facility for 10 years with people who had dementia, and it was very much going into their reality and meeting them where they are. And I think that gave me the skills to really work with people who are experiencing psychosis or are seeing their world differently because they're feeling like this is their last day of life, or that they might go harm somebody, and being able to mold myself into their world and not expect them to come to mine has been a huge plus and a huge skill set that I was very happy to bring to Crisis, and really happy to work with the community in general, because making sure that people always feel heard no matter what reality they're in, and that they're safe, is the most fulfilling and amazing work that I think anyone can do.